Really honored to have her here today to talk about her research on Cabergoline for lactation inhibition after early second trimester abortion or pregnancy loss, eLISTA, a randomized controlled trial. Welcome, Dr. Henkel.
Thank you so much for that introduction. Now seeing all of the very impressive speakers that are lined up, it's quite intimidating to speak today, but thank you for this opportunity. I am excited to talk about this project and kind of larger goals with this topic. This project was funded through the Dunlevie Center through a seed grant for clinical educators. So I want to start out with appreciation for the Dunlevie Foundation. I also want to point out how many collaborators from a very intersectional group of people helping me in this space. Multiple of my complex family planning colleagues, as well as experts here at Stanford in lactation medicine, lactation consultant, MFM, to help make sure that this research is as impactful as it can be across kind of all domains of obstetric care that it touches. So before jumping into actual research, I want to review some physiology of lactogenesis and the prevalence of breast symptoms following abortion or pregnancy loss in the second trimester. We'll discuss the literature around emotional and physical distress caused by breast symptoms, and then the options for lactation inhibition, symptom suppression, or memory creation. I will briefly review the interventions for lactation inhibition and finally get to the randomized trials. So lactogenesis is a two-stage process, and starting around 16 weeks gestation, high levels of estrogen, progesterone, and prolactin stimulate anatomic growth of the breast. And this is something we see as obstetricians where patients are coming in reporting pretty early breast pain in late first trimester, early second trimester. Stage 2 lactogenesis is kind of what we think of more of milk creation, and this doesn't occur until after the removal of the placenta. Following the removal of the placenta, there's a rapid drop in progesterone levels that removes the antagonizing effect of prolactin, leading to milk production. And this feedback mechanism continues by the baby suckling. So the suckling at the breast sends essentially like the anterior pituitary secretes prolactin, the posterior pituitary secretes oxytocin, so that both milk is produced and let down. And ultimately, if there is not this physical stimulation, lactation does eventually stop. And this occurs regardless of there being a live-born infant or not. There are multiple studies about the emotional pain of breast symptoms following a loss. In one set of qualitative interviews, the themes that came from this was that breast engorgement was seen as a reminder of the loss. And it's very hard for patients to reconcile the motherhood identity associated with lactation with the absence of an infant. There's a lot of frustration surrounding the lack of knowledge about milk leakage and available treatments. And the pain from lactation really exacerbated the psychological pain of the loss. As one participant stated, it was not only the physical pain that bothered me, feeling pain in my breast and knowing that there was milk and having no child to feed was agonizing. And another qualitative study, people universally reported that they did not expect to lactate following a loss. And so many in this study didn't consider medication necessary because they didn't think it was going to be a problem. In reality, many felt they really had inadequate lactation support, and the pain really prevented them from having closure around the loss. As one participant stated, my heart ached as I woke every 2 hours with breast engorged with milk and no baby to drink it. I realized my milk was going to come in whether I wanted it or not. Unfortunately, physical pain associated with breast engorgement after an abortion or pregnancy loss really had not been completely characterized. It was something clinically we've all seen, but not a lot of attention was paid to. And this is from a trial way back in 1990 that kind of gives us, since there's a placebo, the best idea of how many people report breast pain. So this was 18 individuals, so a pretty small number, and 91% reported breast pain. 89% reported milk secretion after a second trimester abortion. So many, most, nearly all are having these side effects. Similarly, there was a conference abstract from 2020 that prospectively followed 27 individuals at a median gestational age of only 17 weeks. And they similarly reported that 50% of people had breast tenderness, 20% were leaking milk in the 2 weeks following an abortion. We conducted here at Stanford a national web-based survey of abortion providers on a Facebook group and asked providers what were their practices and had they seen patients with breast pain following a second trimester abortion. And the vast majority, 92% of respondents, reported that they have seen patients report breast pain and milk leakage following a second trimester abortion. But at that time, only 18% of survey participants were offering any sort of pharmacologic modality. And at that time, kind of a variety of meds were being used. So kind of prior to starting our work, we really wanted to think about what do our patients want? And again, there's quite a bit of qualitative data around the experience of lactation following a loss. And I think this participant really says it best. She said, I want someone to say, this is normal. Your body is actually working really well. But now that's not what we've got to do because the milk is not needed in this context. So this is what we can do to help you suppress it. So I think we've established pretty clearly here that lactation following a second trimester abortion or pregnancy loss is expected. So our options at this, so we have a couple of options for management at this point. One option is expressing milk. And similarly, this has been studied qualitative in the past. One participant describes the process of donating milk was actually, or even of expressing milk, was almost meditative. It was a time that I could relax and think about Archie, our son. So if someone is expressing milk, they can donate the milk, and that can go to a milk bank. Here at Stanford, our NICU relies primarily on the Milk Bank of San Jose. Unfortunately, there are multiple contraindications to donating human milk. And it is important if talking to interested patients to be aware of these contraindications, because obviously that'd be quite sad to be talking about it and then not be allowed to. Kind of the ones that I've seen come up are the recent blood transfusion or prescription medications that they might be on. Alternatively, breast milk jewelry is a really lovely way to kind of remember the pregnancy. And this can just take a very small amount, just as little as 15 milliliters of milk. So it could actually be combined with other of the options that we've discussed. And this can be a way for a grieving parent to remember the pregnancy. Option 2 is more supportive measures. So we're not preventing lactation here, but we're more supporting people through that inevitable kind of 2-week period of engorgement, milk leakage, and suppression as there's not physical stimulation. And kind of classically, many people talk about cold cabbage leaves as supportive measures. People have looked at this in a relatively methodologically sound way, comparing it to alternatives such as hot and cold compresses. And really, like, neither of them are all that effective at decreasing pain. Similarly, we talk about support bras or tight, any sort of like tight support. Kind of same idea of maybe some minimal change to symptoms, but people still do lactate, still are engorged, and will have pain. This problem, is not new to this century. Certainly, midwives have been aware of lactation after a loss for centuries. There are all kinds of other described herbal remedies, vitamins, and in a Cochrane review, really, there's no evidence that these non-pharmacologic interventions lead to a more rapid resolution of symptoms. So supportive, but certainly there's room for innovation. The third option is to inhibit lactation. And before we get into kind of most of this discussion, I think it's really important to go back and think through the timeline around pharmacologic interventions for lactation, because it really informs why we are here, in 2025. So in 1980, the FDA approved bromocriptine, trade name Parladel, for postpartum lactation inhibition, specifically for that indication. And it was approved off of multiple small studies where it was pretty well tolerated. And this became quite common. Many people were choosing to inhibit lactation for convenience because they were using formula for their babies. This was not primarily surrounding loss. Then, in the 10 years following its approval, there were a few case reports of some hypertension, seizures, even one fatality following a stroke. But still, for the number of people who are using this medication, that probably is around population level. But it was enough that the FDA had asked the manufacturer to stop selling the drug. And at that point, they declined to do so. Then in 1994, there were kind of additional reports of stroke, MI. This resulted in multiple lawsuits against the manufacturer. Again, if we really think at a population level, this is probably not related. This is a commonly prescribed medication. And as obstetric providers, obviously we do see strokes and MIs, unfortunately, in our patients. But that same year, the manufacturer of Parladel merged with Gerber. Gerber, like the baby food, very pro-family, pro-baby image. And the amount of money being made from this medication was pretty minimal. So ultimately, Gerber decided that they were not going to market Parladel for this indication. They felt like the lawsuits were just not worth it. So this really had a chilling effect on any pharmacologic options for lactation inhibition for like a decade and a half. And then in 2020, when the Health and Human Services was a functional department in our government, their panel on treatment of pregnant women with HIV infection and preventing perinatal transmission recommended routine use of Cabergoline for lactation inhibition for those with contraindications to breastfeeding, so like high viral load. And this really opened the door for additional uses of Cabergoline. So Cabergoline is a dopamine agonist with a relatively long half-life. And Cabergoline has been compared to bromocriptine, another dopamine agonist, in the past for lactation inhibition after third trimester full-term births. And compared to controls who their prolactin levels remain high, bromocriptine and Cabergoline are both quite effective in suppressing prolactin and decreasing symptoms, though Cabergoline a little bit better than bromocriptine. Also, because of the half-life of bromocriptine, the prolactin levels tend to jump again kind of after a week. In the early 2000s, there was actually a small trial that occurred in the Czech Republic comparing Cabergoline to another dopamine agonist, Tergurid, which I don't believe we have in the United States, looking at a one-time single dose of Cabergoline to a 10-day course of this other dopamine agonist after second trimester abortion. And they found that the lactation inhibition was similar between the two meds. So, obviously preferable to have a one-time dose. Similarly, in 2020, there was a big review article that was looking at Cabergoline for postpartum lactation inhibition or suppression, said that it was well tolerated and pretty minimal side effects, with more studies looked at, kind of the concern around stroke, MI, these really adverse events. It appears that those really weren't related to the use of the drug. So that kind of opened the door for our first study, which was Cabergoline for lactation inhibition after second trimester abortion or pregnancy loss. This is my fellowship project, and it was incredibly impactful. It was a featured in the Green Room podcast. It was like a top 3 abstract at ACOG. It was an ABOG MOC CC, or whatever the new term is, article. And people knew about it and have very rapidly implemented the use of cabergoline. So that trial, we recruited people who are 18 to 28 weeks gestation, who were seeking care at Stanford for an abortion or for fetal demise. And we randomized them to cabergoline 1 milligram once, or placebo at the time of their induction, or D&E. We enrolled 73 people with a median gestational duration of 21 weeks, reflective of our tertiary referral status. People were relatively far into the second trimester. And we found that cabergoline was quite effective in inhibiting or preventing breast symptoms following the second trimester abortion or loss. This is the percentage of participants with breast symptoms. Here, those with placebo, nearly 100% of people receiving placebo were symptomatic, compared to 20-something% of those who received cabergoline. So quite effective, well tolerated. One of the primary criticisms of this initial paper was fewer than 1% of abortions occur after 20 weeks gestation. And most outpatient clinics really are only providing abortion care up to 20 weeks. And in this initial trial, again, as a reflection of our Stanford population, we recruited very few people who were under 20 weeks. And essentially like 9 people received cabergoline who were under 20 weeks. And so in this exploratory sub-analysis of those who are 18 to 20 weeks, we actually did find a statistically different proportion of people experiencing symptoms on day 4 and 7, but it was so few participants that organizations truly were reaching out to me saying, we don't feel like we can implement this on a broad scale off of 9 patients receiving cabergoline. So this led me, and similarly, this study was picked up, SFP and SMFM in their joint clinical recommendations around medication abortion in the second trimester. They write, lactation is likely after abortion at 18 weeks of gestation or later. If pharmacologic management is chosen, cabergoline is effective and generally safe with few adverse effects. And they cite my study. But again, as we described early on, we know from physiology lactogenesis starts around 16 weeks. And we'd had multiple organizations be concerned about implementing cabergoline under 20 weeks in these outpatient settings because of how few individuals had received the drug in the original trial. So that led me to seek this Dunlevie funding to ask, does cabergoline similarly prevent symptomatic breast engorgement after early second trimester abortion or pregnancy loss? The trial design was similar. It was a superiority trial. It's double-blinded, multi-site, recruiting at Stanford, LPCH, and Planned Parenthood Marmonte. And we intentionally gestational duration stratified to be powered in both the 16 to 17-6 group as well as the 18 to 19-6 group. It was block randomized with the planned modified intention to treat design. We recruited pregnant people who are 18 years or older, English or Spanish speaking, 16 to 20 weeks gestation, seeking abortion care or management of fetal demise, and they needed to have internet access. We excluded those without breast, or those who are using dopamine agonist or antagonist, or other contraindications to cabergoline. We received IRB approval, we prospectively registered it on clinicaltrials.gov, and received one of the last NIH certificates of confidentiality. To measure breast symptoms, we use the validated Bristol Breast Inventory. So this survey measures the kind of 4 domains of breast symptoms, that being engorgement, milk leakage, tenderness, and need for pain relief modalities. And a score of 1 reflects an absence of these symptoms, and 2 through 4 is kind of increasing degrees of how symptomatic they are in each of these domains. And for our primary outcome was an absence of symptoms. And this was based on initially in the first trial, our kind of community partners, lactation specialists, really had guided us that in absence of symptoms was what patients wanted. So to be most clinically meaningful, our goal is that people have no symptoms. And to be classified that way, they needed to answer 1 in all 4 domains of engorgement, tenderness, leakage, or pain relief. We also calculated a cumulative score by adding up all of the 4 domains. So as mentioned, our primary outcome, breast symptoms on day 4, and we determined that we would need 30 participants in each gestational age strata, so like a total of 60 total participants, to show a 40% decrease in those reporting breast symptoms. We plan to also look at breast symptoms on other days, satisfaction, acceptability, and side effects. So what this looked like is participants were approached prior to their procedure or induction. And at this gestational duration, this is a 2-day procedure with cervical prep. So after being consented for D&E or induction, they completed a baseline survey. They then had their procedure or their induction where they received either placebo or cabergoline 1 milligram once in a blinded fashion, and then again completed surveys on days 2, 4, 7, and 14. We assessed 145 individuals for eligibility and ultimately randomized 69 individuals. We had 3 individuals who were lost to follow-up beyond that initial allocation day. So to our clinical research coordinator's great credit, she was incredibly persistent and effective in getting follow-up data for us. And the primary reasons for people not participating or not being eligible was speaking a language other than English or Spanish, or currently breastfeeding, where they plan to continue to breastfeed. There certainly were individuals, we had 42 individuals who just declined to participate in the study. So in this trial, our median gestational duration is 18 weeks, which makes sense because we were intentionally gestational age stratifying and 16 to 20 weeks. 76% of individuals in this study were facing an undesired pregnancy, and only 5% with a demise, and 96% underwent a D&E. About half had previously breastfed an infant, 68% were publicly funded, and 63% were Hispanic ethnicity. So similarly, we found that cabergoline was quite effective in preventing breast symptoms following these early second trimester abortion or pregnancy loss. Here, the dashed line is those who received placebo. Over 90% of individuals receiving placebo were symptomatic on day 4, compared to around 50% who had received cabergoline. And even in our gestational strata, we found that cabergoline was quite effective in decreasing the number of people who are symptomatic following an abortion or pregnancy loss. So yay, it worked. We also looked at the cumulative Bristol Breast Inventory score and compared to baseline, so 0 and above here, these are people who are more symptomatic following their abortion or loss. People who received placebo were significantly more symptomatic on days 4 and 7 compared to those who received cabergoline. Again, that makes sense. We also asked people how bothered they were by their breast symptoms. And we found the median bother score was lower in those who received cabergoline compared to the placebo on days 4, 7, and 14. We also classified being significantly bothered as a score of 4 or higher on a scale of 6. And there are more people significantly bothered who received placebo on days 4 and 7. We asked about side effects on days 2, 4, 7, and 14. And these symptoms, 85% of people reported symptoms at some point. These symptoms were actually quite common, ultimately. Interestingly, more people who received cabergoline reported nausea or vomiting at any point in the 2 weeks following their procedure compared to those who received placebo. This was not a finding we had in our first trial. but otherwise quite similar between the two. So, strengths of this study, the randomized design, we were able to recruit a diverse participant population using preferred language questionnaires between two sites. The study team was very intentionally created to include experts, MFM, CFP, breastfeeding medicine, lactation consultants to ensure that our outcomes were both clinically relevant and patient-centered. We very intentionally had a power calculation that accounted for both of the gestational age strata. So I think that people can very confidently start offering this at 16 weeks gestation. And also just the generalizability, the multi-site design, we're taking care of patients both in outpatient settings as well as hospital-based care. Weakness, we did not collect information about why people declined trial enrollment. It's unclear, did they not want to participate in research? Are they not interested in a pharmacologic method? This is definitely an area for future research. So where do I want to take this next? I think my immediate next step is recognizing that prolactin levels here in the second trimester are at least half. Like they're much, much lower than what they are at full term. And the initial dosing of 1 milligram, we selected this based off of full term studies because that's where the data was. But I think it's really quite plausible that a lower dose would in fact be effective, especially in the early second trimester, and possibly with fewer side effects. So I think that is, if I can find some funding, what I want to study next. And I think a meta-analysis for side effects would be helpful as we counsel patients about what to expect with this medication. I just want to talk briefly about how, as a CFP provider, I talk to our patients about lactation, because often these are many of your patients that we are seeing, you are being MFM. So we provide anticipatory guidance around breast engorgement for all of our patients receiving care for abortion or pregnancy loss in the second and third trimesters. This information is provided both during counseling as well as an after-visit summary. We discuss available options so that they can make an informed decision about what they would like to do about this anticipated normal physiologic outcome. So that includes options for pharmacologic inhibition with Cabergoline, non-pharmacologic supportive measures, milk donation, or memory creation. And then we provide resources based on patient preference. So that's dispensing or prescribing Cabergoline or offering contact information for local milk banks, etc. So in conclusion, breast engorgement is common after abortion and pregnancy loss in the second and third trimesters. The severity of bother, I would say right now, is pretty underappreciated, undertreated, had been classically by most providers. Patients really want and need anticipatory guidance, and we have now quite convincingly shown that a one-time dose of off-label Cabergoline at the time of management of second or third trimester abortion is safe and effective in preventing symptomatic breast engorgement. That is all I have. I'd be happy to take any questions.
Thank you so much, Andrea. What a great review and innovative study with such immediate clinical applicability and relevance for patients. Really well done. Do you have a sense? I'll offer a first question here and let others chime in. But do you have a sense of how widely this has now been adopted?
Yeah, not like quantitatively, but recently Dr. Shah was at NAF and she just asked people to raise their hands at how many people were offering Cabergoline, and it was near universal. It's actually really so lovely. I spend time on kind of multiple social media platforms, and people will talk about and actually kind of misquote my study at times where I'm like, whoa, that wasn't exactly what I said. So people are very aware of it, and especially at academic centers. I think academic centers near universally applied at this point.
Well, congratulations. That's fantastic. And hopefully you can get the word out because it's such an incredible intervention for these patients.
Yeah.
I see Danielle has her hand up.
Thanks. Hi, I just want to echo that. Huge congrats. I mean, what an amazing project to do, starting from when you're a fellow to being junior faculty. I mean, to get these done is amazing. So you should be very proud. I have a question and I might have missed it. Have you looked at the mental health sequelae of, I saw a lot of the symptom reduction is between days 4 and 14, but then a lot of even the control people end up kind of at that same place by day 14. Have you looked forward to see what the effects are of reducing engorgement in that window? Like, does it help people recover emotionally faster? Are they less traumatized when they get pregnant again?
Great follow-up question, and that is a planned secondary analysis of this data. We asked people at that day 2, 4, 7, and 14 about perinatal grief. So unfortunately, did not expand beyond the 2 weeks, but in this final analysis, there actually is a difference in the median grief score, which is exciting that potentially this also decreases or improves experience in some way. I think it'd be fun to, look at longer term and especially in a subsequent pregnancy and subsequent breastfeeding outcomes of how do they feel about lactation in the future.
That's great, and you should for sure.
Any other questions, thoughts from anyone? Dr. Gallagher says such great works. Thanks, Dr. Henkel. Can you elaborate on contraindications, specifically poorly controlled hypertension? It came up on an OB Cards conference several months ago, and curious your thoughts on who really shouldn't be offered. That's actually a great question too. Thank you.
Thanks. Yes. So most people are eligible for Cabergoline. Those with a history of fibrotic lung or cardiac conditions should not receive it. And then as a real absolute contraindication, the softer relative contraindications are those with uncontrolled hypertension. And the reason for that is this history of bromocriptine being associated with stroke or MI. In reality, dopamine agonists should actually drop people's blood pressure. So it's a little bit like we're just being very conservative with this being a contraindication. So if someone receives it who does have uncontrolled hypertension, I don't think, I've also received that phone call of, oh my goodness, we gave this to someone with preeclampsia. Like, what do we do next? And, just observe blood pressures. But based on those case reports, we're being quite conservative in recommending against any pregnancy-induced hypertension or uncontrolled chronic hypertension receiving it. And then the third would be real psychiatric comorbidities. Those who, like being a dopamine agonist, those who are predisposed to psychiatric illness, like more like we're talking like schizophrenia, that level of comorbidity, it theoretically in larger doses over multiple days could precipitate a psychiatric event.
Dr. Lyle asks, can you expand on which cardiac conditions are contraindicated?
That's, the insert says fibrotic lung and cardiac. I don't know what those are, to be completely honest. I've not encountered someone where that has been a reason that I haven't given it.
And is there, and you may not know, is there a pathophysiology around fibrotic lung that, is it pulmonary hypertensive concerns perhaps, or?
I don't know. Yeah.
That's interesting. Okay. Great. Anything else? Well, we are right approaching 1 p.m. Thank you again, Dr. Henkel. We'll be sure to have you back to learn more as you continue to investigate in these and other areas, and maybe also hear about your global work in Rwanda. So
Sounds good. Thank you so much.
Bye-bye.